Welcome to this narrated PowerPoint summary of the highlights from Chapter 13, which is where we turn our attention from alcohol to looking at drugs of abuse other than alcohol. Again, remember two things that this PowerPoint, which was developed by the publishers, is intended to highlight information that is found in Chapter 13. As I've said previously, it is not intended as a replacement for the material that you'll find when you read the book, so please do not use this presentation as a summary for what you will get from reading the entire chapter. So what you're going to see here are a couple of slides that highlight the main points that you find in Chapter 13, and these are all things that you will have obtained from reading the book. As I look at the PowerPoint right here, a couple things. We will look a little bit at patterns, social costs, public perception, and a little bit at sources of drugs. My primary concern at this point is that you identify really the basic pharmacological concepts of the other drugs of abuse. Also, there's a couple different ways to, quote, organize or classify the different drugs of abuse. We will look at both the DEA classification schedule, but as clinicians, what tends to be more important is organizing the substances according to the various classes. And so we'll look at the DEA schedule, but I also will encourage you to pay attention more to the major classes of the commonly abused drugs. And as you'll see here again, a couple other highlights. We'll look primarily at clinical issues related to the other drugs of abuse. We'll look at pharmacological treatment and pregnancy and use of other drugs. Not a lot of time will we spend looking at international comparisons. I think it's important to recognize that in our global community, there are other perspectives and other drugs and other substances used in other parts of the world. For our purposes in this class, we're going to primarily focus on those things that you're most likely to encounter here. Some quick comments about some information about drug use patterns and how they correlate with these various factors. As you saw in the book, and as you might expect, in general, drug use tends to be higher in younger populations. There is some sense that people tend to age out from a substance use history over time. As our lifespan tends to get longer in the U.S., it'll be interesting to see how those demographics or how that pattern changes over time. But historically, there's been a higher prevalence of substance use among people as they were younger, and tending to peak at the late 20s, early 30s, and decline over that time. Increases occurring in the early to late teens, and continuing to grow typically in the 18 to 20 through the late teens into the 20s, and declining again kind of at close to 30 and older. As you saw in the book, gender-wise, historically, in treatment in particular, there's been a higher incidence of males seeking treatment for substance use disorders than females, and in general, there tends to be more males who experience substance use disorder problems than females. Over time, that gap has been shrinking. And so I'm not sure if it's good news or bad news, but in some perspective, women or females are becoming a lot more comparable to men in the use of mood-altering substances. Substance use and education correlation is not necessarily one that's pretty easy to figure out. There is some incidence that substance use correlates with not just with age, but with education, and that is people in particular who go to school, age out or graduate, in particular out of college. It's typically we see a decline after graduation from college as people seek full-time employment. Similarly, from an employment perspective, there's a slight correlation. Individuals who are employed full-time tend to have slightly lower incidence of substance use histories and patterns than people who are working part-time, who have slightly lower incidence and patterns of substance use than people who are not working at all. So there's a little bit of a correlation, but not certainly not implying a causation of that. And from a geographic perspective, there are some regional differences, and in one of the more recent studies, there were higher incidence of current illicit or illegal substance use in the west and the northeast parts of the United States, and the lowest rate of use occurring in the southern United States. The Midwest, where we're located, is about in the middle. The book does make some reference to differences between urban and rural communities, pointing out that in general there are higher rates of substance use in urban and metropolitan areas, and lower substance use rates in rural communities. And they point out one exception, that there is a difference among youth between the ages of 12 and 17. The chapter talks a little bit about the social costs, pointing out a couple things. There are estimates available about the annual social economic cost of illicit substance use, which was estimated to be about $193 billion. They talk about how that includes both healthcare costs, losses in productivity, and also expenses associated with the criminal justice system. It's difficult to come up with a number or a formula for determining the social costs that everybody agrees on, so recognize that this is one of the attempts to estimate how the impact of the illicit use of other substances impacts overall our economy and our environment. In general, what we talk about from a substance use perspective is that there's a direct impact for people who are using substances that has to do with health and health-related problems, and then also impact on things like employment, income, etc. The healthcare delivery system and costs associated with treating substance use disorders and related illnesses is certainly a big part of it. There's also acknowledgement that, to a large degree, there's a large part of our criminal justice system that really is kept, quote, busy because of the attempts to really address illicit substance use through a law enforcement perspective. And so recognize that the social costs of substance use are not just direct costs to individuals who are using and impacts on themselves, their health, and careers, but also the cost of the system that takes a look at crime related to substance use, substance possession, etc. The next couple of slides will just highlight some of the health problems that are associated with the cost of illicit substances, and they're pretty straightforward and pretty self-explanatory. So take a look at these. Obviously, individuals who are using illicit substances are more prone or more likely to experience accidents or injuries as a result of their substance use. Clearly, if a substance has overdose potential, any overdose is going to lead to the need for medical treatment, so there's costs related to that. In general, people who are using mood-altering substances, especially if they involve injection drug use, typically are going to be more at risk for illness and infection related to the use of needles, exchange of needles, exchange of blood and body fluids, things like that. In addition to the risk associated with needle sharing and the use of injection drugs, if people are inhaling substances, they're going to be irritants potentially to the lung, and so they're going to be at greater risk for experiencing respiratory problems. For those people who are producing substances, there's certainly some risk. Some of the substances involve some pretty flammable or pretty dangerous chemicals in the production process, and so there's certainly cases where there's been explosions, fires, burns, etc., from individuals involved in the production of the substances. People have talked about, and you may have seen on the news, especially when methamphetamine was more prominent, dangers associated with people going into labs that were producing substances and being exposed to toxins, either in the air, in the environment, possibility of explosions, things like that. There is some correlation. There are individuals who, as a part of their efforts to continue to use their substance, are going to be trading sex for drugs, and so for those individuals, there's obviously a risk that goes along with the lifestyle of being a sex worker, and then similar in a way to the use of needles for injection. Subculture that includes tattoos and body piercing also puts the person at risk for possibility of infection and transmission of illness as a result of that practice. There's further discussion of this in the chapter, so take a look at the chapter, make sure that you read it. They did a nice job in the chapter identifying both of these issues. One, that to a large degree, how the public perceives the problem will also then determine how strong and how swift and how well funded the response is. And to a large degree, our response to problems has been associated with whether or not the substance is legal or illegal, licit or illicit, because in general, as we've looked at, alcohol creates a huge, more problems than all the other substances combined. However, alcohol is a legal drug and is perceived as a legal drug, non-problematic. We tend to focus more on drugs because they're illegal or illicit versus legal, and so part of the challenge is how to create an awareness that allows allows the public to respond in a way that instead of using fear tactics or scare tactics, we provide facts, which ultimately helps ideally drive the decision that treatment is a better response to substance use disorder problems than interdiction and law enforcement and things like that. You're obviously getting my bias there. You don't have to agree with that. So, but from my perspective, treatment is really the way to go. You also will have seen reference in the chapter to kind of our early control efforts on substances. Ironically, that substances that were originally perceived to be useful and not problematic or not harmful turned out to be problematic over time. And so we had to learn how to respond to those issues. They talk about two specific federal acts that really set the way for attempts to control access to substances. The first was the Food and Drug Administration that was created by legislatively in 1906, which had specific provisions that were identifying and affecting, quote, narcotics. And then secondly was about 8 years later the creation of the legislation that created the Harrison Act, which then classified certain substances as what were called controlled substances. We're going to talk a little bit later about the current DEA classification system. They do a nice job in the chapter talking about how public perception and public policy, in fact, can or should evolve over time. And we talked on a discussion board a couple weeks ago about medical marijuana, and so I really encourage you to take a look at their discussion. Pretty thoughtful discussion, in my opinion, on is it time to rethink our policy, and a specific discussion about the current sort of experimentation with how we as a nation, how we as a culture are going to address the use and distribution of marijuana in particular. So please take a look at that. Damn it. They do talk about how manufacturers of substances have gone to taken significant action to try to help prevent substances from being diverted to help people get a high. A nice discussion is in there about ways to change the manufacturing process or the agents that are included to make it more and more difficult for individuals to divert their product and to get the high that they're seeking to obtain. So as we look at the impact of these substances other than alcohol, there's really some primary concepts that we want to understand. One of them is the route of administration, how a substance actually enters into the body. Depending upon the route of administration, there can be either quicker or shorter action of the substance once it gets into the system. We also have to understand that different substances affect different parts of the body, and in particular different parts of the brain. And so where is the site of action, where is it, and how is it that that substance works? We also have to understand how quickly or slowly a drug is metabolized, how quickly or slowly it's broken down and removed from the body. We talked earlier about the metabolism of alcohol as being a priority of the liver, and then also understanding the impact of a substance based upon how soluble it is in the body, and if it's soluble in fat, if it's soluble in water, or in some cases if it's soluble in both. Depending on what it dissolves in and what it's soluble in, can impact where it can get to in the body. So two other basic concepts you're going to be familiar with is the concept of withdrawal. We talked about this a bit earlier with alcohol withdrawal. So withdrawal is that the syndrome of distress or discomfort that emerges if the person is no longer using or under the influence of their drug of choice. The symptoms are specific to the drugs of choice, and so there is no one withdrawal pattern. It really is substance specific. The other thing is abuse potential. Some substances have a high abuse potential, some have a low abuse potential. They're basically determined by how quickly the substance acts once it gets into the system, and that is also to a degree influenced by how the person uses it. If the drug gets to the brain quickly, i.e. injection or inhalation, it's got a quicker action, quicker speed of action. If the drug is swallowed or taken orally, it tends to have a slower speed of action. And so speed of action in general and influence by route of administration is a part of the abuse potential. Also how long the effects are experienced for, the duration of the action, and whether or not the user experiences the effects as pleasurable, as unpleasurable, those kinds of things. The way to understand this is to recognize that the sooner the effects are felt after the use of a substance, and the stronger the effects are, the greater the risk or the likelihood of abuse occurring. So that would be a high abuse potential. Cocaine, for example, once a person uses cocaine, it acts very quickly on the brain in particular, so very rapid onset or speed of action. It also actually has a relatively short duration. Cocaine users tend to start to come down from the drug pretty quickly, and so you have to repeat the substance to maintain the effect. So high abuse potential is typically going to be rapid onset or speed of action, a short duration of action, and strong or more intense effects are all going to make it to have a higher abuse potential. The authors do a nice job summarizing some of the problems associated with the use of illicit substances. Obviously, some of them are just the properties of the substance itself, and in particular, obviously the risk of substance use disorder or dependence developing due to repeated and regular use of the substance. Certainly, especially for illicit substances, there are no quality control measures in place, and so not at all uncommon for illicit substances to be caught or adulterated with contaminants and impurities that can potentially present some problems once they get into the system. Also, the other is the byproducts of metabolism. As a substance is broken down, there's the potential that the results of that breakdown could then introduce into the system substances that are contaminants that are potentially dangerous. They do a nice job about describing that relative to the presence of demerol and piperidine and how that was a problem replicating or simulating the symptoms of Parkinson's disease. The other potential problem is relative to how the person is using the drug. We hinted at this a little bit earlier. Obviously, if you're injecting a substance, then there's potential problems at the injection site, the use of contaminated needles, abscesses, infections, things like that. So depending on how you're using a substance, if you're inhaling it, then you potentially have some inflammation or some problems relative to the nose, to the lungs, things like that. And so there's certainly potential problems there. And then some substances have a higher potential for being toxic, i.e. a lethal dose, and the person overdosing. Table 13.3 talks about the lethal doses of abused psychoactive substances, and you're going to see that there's a pretty broad range there. They talk about what's called the safety ratio, and be familiar with that concept because depending upon the substance and how it's used and how either small or large the safety ratio is, indicates how dangerous use and how likely the risk is of overdose to that particular substance. The first classification system that the author talks about is a system that was developed by the Drug Enforcement Administration. It's an outgrowth of the Harrison Act that we made reference to earlier, which basically takes a look at classifying substances on a Schedule 1 through Schedule 5 basis relative to the abuse potential of the substance, as well as whether or not the substance is considered to have any acceptable medical use. From a DEA perspective, the most dangerous substances are classified on Schedule 1. As you see here, there's a high level of abuse. They are also are substances that are considered to have no acceptable medical use, and on that schedule includes heroin, LSD, and cannabis. Again, it's important to recognize that, so on the federal level, the feds have still classified cannabis or marijuana as Schedule 1. Many states have permitted it to be used for medical purposes and in some cases for recreational use. And so there is a clear split between the federal classification system and the state's treatment of that substance. Moving ahead, you'll see that as we move what I call lower down the classification scheme, if a substance is classified as Schedule 2, it now has some accepted medical use, but it is also considered to have a high abuse potential, so prescriptions of Schedule 2 substances are not refillable. It'd have to be seen again, and there would have to be a new script issued. That includes substances like methadone, morphine, amphetamines, coke, oxycodone, etc. Schedule 3 substances are lower on the risk scale than obviously Schedule 2. There is considered to be a moderate risk of physical dependence, a higher risk of psychological dependence, and you'll see a couple substances listed here as examples of Schedule 3 substances. Then moving to both Schedule 4 and Schedule 5. Schedule 4 substances are considered to be relatively safe. There is some risk, but low risk of physical dependence. There's moderate risk of, quote, psychological dependence and clearly accepted or established medical use. They give some examples of substances that are classified on Schedule 4 here. And then finally, they talk about substances that are classified on Schedule 5, lower risk of dependence, and established medical use. They are still controlled, they are still monitored, but they're considered to be lowest on the potential problem scale. And take a look, if you don't know what Lamodal is, take a look at what it's used for. As a clinician, so the DEA schedule that we just looked at is a legal system for classifying substances, not based upon their properties, but based upon, again, abuse potential and medical use. As you saw, many of them had analgesic or pain-relieving properties. As a clinician, what is more useful typically is classifying substances based upon their biologic or pharmacological effects. And so we will now shift our attention away from the DEA classification system and look at classifying substances based upon their pharmacological effects. This is really consistent with what you're going to find in the Diagnostic and Statistical Manual 5, or DSM-5, where it organizes substances into various classes from a diagnostic perspective. Recognize that there are some substances that are not considered to be their own specific class of substances, such as club drugs. So on occasion, you're going to have a user who you're going to have to look at various classes to diagnose whether or not he or she has a disorder. And then there are always attempts to stay ahead of the illicit substance category by producing synthetic and sometimes mimetic substances, synthetic cannabinoids, or synthetic cathinones that are sold because they replicate the effects of the substance. They have not yet been classified as being illegal, and so people use them as a way to, quote, get a legal high. Once the feds determine that there's a problem, they oftentimes will then look to outlaw it, but it becomes kind of a cat and mouse game where then the manufacturers alter the formula slightly to still have a similar substance that can give people the desired effect. As we walk through the classification system here, you're going to typically see 3 or 4 slides on the various substances, and so I may make some introductory comments on the initial slide. The rest of it is pretty self-explanatory, so I encourage you to move through this section, read it, and then move forward when you feel like you're ready to move ahead. They do talk specifically about nicotine as a class of substances, and the chapter talks about actually the very high abuse potential. Nicotine produces a very strong dependence. People use nicotine are easily classified as severe nicotine use disorder, and so these slides talk about some of the properties of nicotine that make it more challenging. One of the interesting things about nicotine is that part of why it appears to be so have such a high abuse potential is that the body's very receptive to it. There are nicotine receptors present throughout the brain. Someone uses nicotine, there's almost a predisposition to want to have that substance in your brain. The other thing is that there's kind of a synergistic effect. Nicotine appears to enhance or multiply the effects of many other drugs. There's a pretty high correlation between people using alcohol, people using nicotine in particular, but there's also a correlation between nicotine and other substances. They do talk, and take a look. We talked earlier about how when alcohol is prioritized by the liver to be metabolized, then what it does is it interferes with the metabolization of other substances. And as you see here, nicotine is one of the substances that has to be metabolized by the liver as well. So if you're drinking and smoking, then the liver is going to prioritize first the metabolism of alcohol before it then starts to look at metabolizing liver. So you can have, metabolizing nicotine. So you'll have higher levels of nicotine in your system when you're combining nicotine with alcohol. Nicotine has a fairly short half-life. Half-life is a concept as to how long does it take before half of the substance has been metabolized or excreted from the system. So 2 hours is fairly rapid. That means if you've used nicotine in 2 hours, half of the substance that you've ingested is going to have been metabolized and eliminated from your system. And so, after 2 hours, half is there. 2 more hours, half of the half is still there, etc. So you're going to see references to half-life and some other things. The shorter the half-life, the quicker it's eliminated. The longer the half-life, the longer it takes to eliminate it. There is reference to cotinine, which is one of the byproducts and metabolic products of the breakdown of nicotine. And so it's a marker of nicotine, and that's actually remains in the system and has a much longer half-life, a half-life of 16 hours. There's a specific clinical test for nicotine dependence, as I make reference to, which is called the Fagerstrom test for nicotine. You're going to see similarities between the treatment of nicotine, the treatment of other substances, and so when we talk about treatment, we're going to come back to these concepts. But in general, treatment oftentimes for many substances will include combinations of education, support, counseling, in some cases medication replacement for the substance of choice, in some cases therapies to help people go through the either the withdrawal, the detox, or the stabilization process. There's a nice discussion in the chapter about the history of the use of opiates, beginning with the use of opium, which then was refined to produce morphine, which then was refined to produce heroin. And so, nowadays, in addition to opiates, we have the ability to chemically synthesize or replicate and make even better forms of analgesics. Opiates are painkillers, narcotics are painkillers. There's analgesic or painkilling properties. And so they do a nice job talking about that, about the history of opiates and its use in our culture. Part of why it is such a high abuse potential. It has quick onset or rapid onset, so the effects come pretty shortly after using. And they're also, it's excreted or metabolized. It has a fairly short half-life, and so you have to use more to continue to get the same effects. They make reference to the to how there is a kind of a rising and falling use of substances over time, and how at some point there was a reduction in the use of heroin, in particular of opiates, which appeared both to be relative to how easy it was or how difficult it was to obtain the substance in particular, and also the fact that there was just people aged out of the use, and there was kind of generational memories about, well, only addicts use this and that, and so there was kind of a bias or stigma against it. In my opinion, they talk about there's been an emergence with a new set of users recently, and they seem to attribute that to both the fact that it is readily available, it's available at a better price, and there's now also a greater purity. They don't seem to pay as much attention to opiate use as I think we're seeing, and so it's interesting to me because I think not just here in the Chicago metro area, but across the country, there's been a huge increase, especially in opiate use, heroin use, among a much younger generation of users. And so we're seeing more and more calls for things like treatment, better methods to treat opiate addiction or heroin addiction, greater actually interdiction controls on the use of and prescription practices about analgesics and narcotics. I think you probably just have paid attention to the fact that many pharmacies now are allowing people to purchase naloxone, the overdose reversal substance for opiate users without a prescription. And so I think the authors weren't quite up to speed with how much the opiate problem has been emerging here in the United States in recent years. They do talk about treatment approaches, and there's a variety of treatment approaches. In some cases, there's detoxification, traditional detoxification, or substitution of methadone. There are some higher priced, newer developed detox techniques, one called ultra rapid detoxification, or UROD, which introduces a blocking agent to eliminate it. There's a slightly slower process called rapid detoxification, which uses naltrexone as well as other medication to help the person, quote, detoxify or eliminate the heroin from the system. Criticism that have been that even if you eliminate the substance, there still needs to be lifestyle changes. So pay attention to that discussion in the book. The next class of substances that we'll take a look at are what are classified into the either as sedatives or hypnotics. These are all central nervous system depressants. So if you're recalling what we talked about with alcohol, so the use of these substances is going to have an impact very similar to the use of alcohol, relatively minor in that overall it's used by less than 1% of the population. Common uses are benzodiazepines, Valium, etc., also barbiturates and meprobamate. These are all central nervous system depressants, which means after use of the substance, it's going to gradually have all the same impact that alcohol does. Decreased response time, decreased respiration, decreased pulse, things like that. So use of these substances is going to have impact very similar to use of alcohol. It's also part of why it's dangerous to combine alcohol with these substances, because they're synergistic, they multiply the effects, and so therefore if the person's drinking and taking a sedative, he or she is at greater risk of overdose because of the combination of the two substances. There's reference in the chapter to a less common sedative called GHB, gamma hydroxybutyrate, sometimes street name called grievous bodily harm. In recent years, not very common here. It may show up again. These are its characteristics. Things come and go over times, but this is not one that currently has a strong presence in the Chicago metro area. You'll see that the problem there is that there's a pretty close, there's not much distinction between a dose that causes the effects of the substance and a dose that causes sedation. And so if you take a little bit, you might feel good. You take a little bit more, you're going to be too strongly or heavily sedated. So that's a challenge for the user. These are going to be very similar to, again, as I said earlier, the impact of the use of sedatives and hypnotics is very, very similar to alcohol. So take a look at the symptoms here. These are the pharmacologic or characteristics of sedatives and hypnotics. Pretty self-explanatory. And as I said earlier, there is unfortunately the strong likelihood of interaction between the use of sedatives and the use of alcohol. They're synergistic. They multiply the effects, and in particular, they have a pronounced effect on breathing or respiratory distress. They impair breathing, which obviously becomes potentially life-threatening. If a person is actually in withdrawal from alcohol, because there's a cross tolerance between alcohol and sedatives, then the typical approach to helping someone safely withdraw from alcohol is going to be use of Valium in particular. And so because there is a cross tolerance, we can eliminate the alcohol and then provide a medical use of Valium, and then just decrease the Valium dose over time to help the person safely withdraw from alcohol. The next class of substances actually have the opposite effect of the sedatives and the hypnotics. These are the broad category called stimulants. These also affect the central nervous system, but as opposed to depressing it, they increase it. They stimulate the central nervous system. So instead of decreased pulse, respiration, heart rate, etc., we now have increased pulse, respiration, heart rate, actually decreased reaction time in this case because it speeds up the responses, things like that. There's both legal and illicit substances that are part of this category. Those are all listed here with a more extensive list in the book. In recent years, there's been a little bit more attention paid to the methamphetamines. First, recognize that both amphetamines and methamphetamines are substances that have stimulant properties. Methamphetamines actually have a longer half-life in the body, and therefore people using methamphetamine were experiencing the results or the impact of the substance over a longer time period than people using amphetamines. It was more of originally a coastal experience. There was a lot of meth being used on both the East Coast and the West Coast, and then it gradually made its way to the midsection of the country. But even in Illinois, it tended not to have as strong a presence here in the Chicago area as it did in rural parts of the state, things like that. And so at this point, methamphetamine, while still a problem, is considered secondary to other substances. And in particular, as I said earlier, we've seen more increases in opiate use and the use of heroin in particular, but prescription opiates as well. Cocaine also is in the stimulant category. This is another substance that has peaked and valued over time. Tends to be correlated with the prime substance using category, age 18 to 34. It peaks and valleys. It can be used in a variety of ways. It can be snorted intranasally. It can be used intravenously. It can be smoked as freebase. Once it gets into your system, it has the same impact, but the difference is that the quicker it crosses a blood-brain barrier and gets into the brain, the stronger and the more rapid the onset. And so you can get it into your system pretty quickly if you snort it. If you smoke it, you get the system even quicker because it gets in the lungs, gets in the brains. Intravenous injection also is pretty quick, but smoking is really considered to be probably the quickest rate or means of onset of cocaine use. There is a quick discussion about hallucinogens and dissociatives. Hallucinogens like mescaline, psilocybin, and LSD oftentimes early were produced by plants. They have been synthesized or produced in labs as well. They do a nice job discussing this. The history of use outside of just for getting high as a part of religious and other rituals in other parts of both the U.S. and in parts of the world. So be familiar with that. The dissociatives is a term that many people are not familiar with, and so they do a nice job describing these in the book. They include such things as PCP or phencyclidine, ketamine or special K, some anesthetics. They block pain, and they also induce a loss of consciousness, but if they're used at lower levels, at what are called less than anesthetic thresholds, they produce effects similar to those of other hallucinogens, i.e. people disassociate and they have altered senses of self, of environment, of consciousness, things like that. Some of the club drugs are part of the dissociative category. MDMA or ecstasy is also part of the dissociative category. In more recent years, there's been attention paid to DXM or dextromethorphan, which has properties similar to dissociatives as well. So a nice discussion of these in the book. The next couple slides take a look at the use of marijuana or the cannabinoids, and again, we had a pretty spirited discussion about the use of medical marijuana on the discussion board. So really just highlighting the chemical properties or the pharmacological properties of the cannabinoids and the active ingredient, tetrahydrocannabinol or THC, some of the history here, which many people are aware of. Talking in recent years or concerned in recent years that THC over time, the percentage of THC has increased over time, and so there is some concern that this higher level of THC perhaps makes the use more problematic. Our discussion, I think, highlighted some of the societal perspectives noted here. And so, as you well know, our attitudes towards the use of cannabis is very different from our attitude toward the use of other substances. And again, we had quite the discussion about the medical use of marijuana, and so this really highlights some of the things that are underway. As noted earlier, the feds continue to classify marijuana as a Schedule I drug on the DEA thing, so there is opposition. There is no acceptable medical use from a federal perspective, but many states have decided that they're going to permit it to be used. And it is controversial because there are not unanimous agreement among medical professionals as to the results or to the impact of the use of THC. Take a look at the discussion in the book about the class of substances that falls into inhalants. Not as common as the other substances. There's a couple different subgroups that seem to use them. In some cases, it's younger kids, middle school, early high school, perhaps through high school. And then there's also individuals involved with the club scene who might also be using inhalants. So not as common as other substances. You basically compress and inhale the fumes of a substance in order to get a high or a rush. The challenge with inhalants that we face is that they are unpredictable in dose and response effects. They can lead to cardiac arrest, cardiac depression. They also may have the impact of increasing blood pressure to dangerous levels. Withdrawal symptoms do include craving, but because it's such an uncommonly used substance, there's not a lot of research on this. Also, there is the potential that alcohol can be enhanced or activated, or it's synergistic due to the use of the inhalant of hydrocarbons. So take a look at the discussion of the inhalants. Recognize that they are not as common as the other drugs that we've been taking a look at. We're going to turn our attention now to the use of caffeine. Recognize that in the chapter they talk about the use of some substances that are not commonly abused. These include the androgenic steroids, the steroids in general, and then more recent performance-enhancing drugs like HGH, ephedrine, ephedra, and creatine. So a nice discussion, relatively uncommon, but something that you want to have a familiarity with. These next 5 slides actually take a look at the use of caffeine, included really A, because it's discussed in the chapter, and B, because caffeine is such an accepted part of life that most people don't consider it to be a mood-altering or psychoactive substance. Caffeine does have stimulant properties, and so for people who use caffeine, they typically are familiar with those properties. They tend to help people feel alert and energized, etc. So these slides really take a look at the psychoactive properties of it. Usually consumed in the form of coffee, but caffeine is found in other substances. It can be condensed. I think people know like 5-hour energy drinks and things like that, which may contain higher levels of caffeine, rush, those sorts of things. Energy drinks is something that's been rising, concern about it, but not a lot of data, so we're really not sure what the long-term impact of the use of energy drinks is going to ultimately lead to. Across the board, there is an increase in average daily consumption of caffeine, especially in the United States and in the Western world. Most users are familiar with, in particular, with the acute effects of caffeine. It actually, ironically, slows down communication in the central nervous system, but the user experiences then what they consider to be a better performance, i.e., the ability to be energized, the ability to be focused, the ability to pay more attention, and what is felt as an experience as an heightening or an increase of the energy level in the user. If somebody is using caffeine on a regular basis and they stop using, they can experience withdrawal symptoms. Those are described here. We're going to continue this on the next slide. Continuing to look at, quote, caffeine withdrawal, you'll see here that it's a fairly short withdrawal period, may take up to a day after the person has consumed their last caffeine or caffeinated beverage. Because of the number of users, it is a potential problem, a potentially significant problem. And there may be correlated medical problems that develop as a result of either caffeine consumption or caffeine withdrawal. In an earlier chapter, we talked about prenatal exposure to alcohol. Similar thoughts expressed here. There is a concern about what the influence of prenatal exposure to caffeine is. There is some evidence that says that this may lead to sleep disturbance, and ultimately a child who's using caffeine is going to experience less total sleep overall, impaired sleep, so increased awakenings during sleep, and more lethargy or daytime sleep occurring, which generally are perceived to be problematic. Overall, the effect does seem to be modest, and so some concern, but generally an innocuous perception of that. We're going to come back to, as we conclude looking at these different classes of substances, one of the things that we'll just introduce here, because we'll come back to this in subsequent modules, is so how do we know if someone's use of a substance is problematic? That really comes down to an assessment, and in particular, I think one of our earlier modules just had a quick overview of the DSM-5 criteria for diagnosing a substance use disorder. We will come back to this, but ultimately recognize that there are a total of 11 criteria that we use to determine whether or not there's a substance use disorder. And that's going to be classified, if they meet criteria, anywhere from mild to severe substance use disorder, mild, moderate, and severe. There are different criteria that are used for different substances, so we diagnose people based upon their drug or drugs of choice, and we take a look at each of their uses of substances. The other thing that the authors talk about, when we talk a little bit about treatment, many times treatment is going to be focused on the goal of abstinence from all mood-altering substances. Treatment goals can also be approached from, or treatment can be approached from a harm reduction perspective. In this case, the goal is not necessarily or ultimately abstinence. It's basically how do we reduce the risk or the potential harm that might be occurring associated with the use of their substance. And so if you're an injection drug user and you can have clean needles, i.e. needle exchange program, then that reduces the risk of harm. And so sterile injection practices and needle exchange programs are one example of harm reductions. As I talked about earlier, now there's the ability to obtain the naloxone without a prescription in Illinois, which basically is an antagonist that helps prevent overdose from opiate use. And so this is a change in our culture. This is a change in our perception. Clearly a harm reduction approach, because what it says is, look, we need to keep these people alive. We're not going to make it hard to get these overdose reversal kits. We're going to make it as easy as possible for people to have them available. So again, harm reduction, the ultimate goal is to say we're not focused on abstinence only, and we're looking at reducing the risk and the problems associated with the use of the substance. It is targeting people who are not yet in treatment, people outside the treatment arena, and trying to get them in. It also can be used for people in treatment to help them move towards getting healthier. And if a person's in treatment and continues to use, there still are benefits of reducing the potential risk of harm to themselves and to other people. A more common term than pharmacological treatment of substance use disorder is medication-assisted therapy or medication-assisted treatment, MAT, but recognize that as we begin to learn more and more about substances, we also then identify the benefits of using substances or medication in the treatment process. And that includes things like drug replacements, antagonists and agonists, anti-craving agents, and vaccines that ultimately have the potential to help in the either to prevent or to successfully treat the presence of a substance use disorder. Consistent with our discussion earlier on about fetal alcohol syndrome or fetal alcohol spectrum disorder, similar concerns exist about the impact of substance use on the developing fetus during pregnancy, and obviously because at least some drugs can in fact be passed on to the fetus during pregnancy. Anything that will disrupt or interrupt fetal development, normal fetal development, is potentially having impact across the rest of life. And then also it may present potential complications for the pregnant mother, difficulty in the pregnancy. So a variety of things that make us concerned about prenatal drug exposure. And so the next set of slides will take a look at those. I will make quick comments where I need to. For those individuals who are using opiates, heroin, and other opiates during pregnancy, a couple things highlighted here. You're also going to see a couple things highlighted in the next couple slides about opiate use during pregnancy. In some cases, it's the health of the mother, the lack of potential prenatal care, injection practices that could be introducing infection, etc., into the mom and ultimately to the baby, residing in a high-risk environment. The other piece is that those potential complications then could result in an infant who is born with lower than normal birth weight. He or she could be born prematurely. They may have a lower head size. They may have insufficiently developed breathing or respiratory systems. They may experience symptoms of withdrawal upon birth. So all those complications correlate with poor prognosis for an infant born that has been exposed to opiates in the womb. At the time of birth, the medical staff, the nursing staff, there's a known history of opiate use on the mom's part. These are the kinds of things that would help alert them to the fact that there is a likelihood or possibility of opiate withdrawal, that the infant is now experiencing opiate withdrawal with these symptoms here. Whether or not an infant goes into opiate withdrawal is based upon a number of factors. Certainly part of it is how much and how frequently their mother was using during pregnancy, how close to the time of delivery the mother was using. Ultimately, use close to delivery could ultimately delay the withdrawal symptoms. They may emerge not upon birth, but within a few hours or a day or so after birth. Also, fetal development, the maturity of the baby's own system. They may or may not have the ability to metabolize opiates in their system. These symptoms can be present for up to a couple weeks. They don't have to last that long. And if identified, there can be drugs used as a part of that safe management of withdrawal, the detoxification process. We now turn exposure to cocaine-exposed infants. Upon ingestion, cocaine is easily transferred to the fetus. It is soluble actually in both fat and water, and so it easily can cross through the placenta and be transferred to the fetus. If the mother has been smoking or injecting, then there's a greater likelihood or greater incidence of cocaine transfer. Ultimately, cocaine in the system will constrict or tighten up the blood vessels. It could result in premature labor, so giving premature birth. Unfortunately, it's also associated with increased stillbirths. The baby is dead at the time of birth. And then there's reference to what years ago people would call crack babies, symptoms, irritability upon birth, things like that, as a result upon exposure to cocaine during pregnancy. It's important to acknowledge that for individuals who are using opiates. In some cases, methadone is used as part of medication-assisted treatment, and there are concerns. Some folks are opposed to the use of methadone from a neonatal perspective, i.e., what happens to an infant whose mother is using methadone. Important to acknowledge that there aren't complications, that the use of methadone during pregnancy does not create the same complications for the fetus as the use of opiates does during the pregnancy, and that's always based upon the idea that the person is receiving medical care, they're taking the proper dose in order to not have adverse impacts on the infant. And typically, if somebody's using methadone while pregnant, it means that they're in fact having regular contact with their healthcare provider. And so important to acknowledge that methadone itself is an important adjunct and can be useful in helping a mom receive treatment without having an adverse impact on the infant. The authors close the chapter by taking a look at really the complications and the issues that arise around working with women who are substance dependent, but also pregnant. And so this just highlights some of the contrast and some of the approaches, i.e. there are therapeutic approaches and punitive approaches, very, very complicated issues without easy answers because the substance use has the potential to impact both the mom herself as well as the infant, both during and after pregnancy. And so thoughtful consideration has to be given to this. What's the best approach? What's the best solution? But as you close that chapter, make sure that you pay special attention to their discussion about the complicated issues that arise when a woman is using while pregnant.